Welcome to this week's episode of Promising Young Surgeon. Today's topic is an important one that will resonate with many in our field: parenthood during medical training. For many physicians, residency training occurs during the childbearing or child-rearing years. And as the demographics have shifted, the physician workforce is increasingly female, which of course affects the resident physician parenthood experience. I am so excited to welcome Dr. Maggie Binder on today, but first we'll open with a very interesting study from the literature. This is out of University of Alberta in 2022, entitled Residency Training Experiences of Residents with Children. For a little bit of background, there are, several themes that have been described in the literature. And again, we'll always link these in the show notes. But basically, I want to bring up the following items. Number 1, female parents are more likely to spend additional time in residency training as compared to male counterparts. Number 2, women spend more time managing childcare and household responsibilities compared to male counterparts. Number 3, role overload is also particularly common among female trainees, as mothers traditionally take a primary role in child rearing. And number 4, positive effects of experiences as a parent on residency training and clinical practice have been described. Some of those positive effects have included a greater sense of empathy or connection with patients, greater enjoyment at work, and reduced depression and cynicism. So going back to this 2022, Alberta study, interviews were completed with 15 of the participants, 11 were identified as mothers, and 4 as fathers. The residents interviewed came from 9 different types of training programs, including internal medicine, neurology, dermatology, pediatrics, including general pediatrics, pediatric cardiology, and neonatology, psychiatry, radiology, and emergency medicine, as well as rural family medicine and OB-GYN. The participants included trainees from a variety of stages of training, ranging from PGY1 to PGY6, which are the first postgrad year through the 6th, respectively. And in terms of the methods, transcendental phenomenology was used as a qualitative research methodology, guided by life course theory. Thematic analysis of the data revealed 7 themes and 14 sub-themes. The 7 themes were challenges of being a parent with residency responsibilities, work-life balance, availability of support systems, impact on patient interactions, impact on other interactions, unspoken expectations, and actionable solutions. So one of the sub-themes that first comes up is that the call schedule is, of course, very challenging. Residents cited experiencing lack of rest and recovery time because of commitments both to their family and to their training programs, often which extend beyond regular work hours. And so, they talk about things like this quote from interview number 7. I think it's a bit of a different sort of a different ball game when you're learning how to be a parent in residency with a demanding schedule. I really want to highlight this one theme, which was unspoken expectations. When asked about hidden curriculum and unspoken expectations, a majority of study participants reported that there's a constant expectation of residents to be ideal trainees and that asking for time off or leaves could be perceived as inappropriate for a good resident. In addition, most participants also reported fear of asking for accommodations because it was seen as an odd thing to do, and accommodations might be viewed by their fellow residents as receipt of special treatment from the program. So, this is from interview number 12 that was conducted, where they have the quote, "That is something like, to be honest, I never actually asked for anything as well because it looks odd if you kind of ask for more days off, or if we want to leave early to accommodate something for your family. It just doesn't look good on you. You almost kind of don't want to ask for more time off, or you don't want to ask to leave early if you have something. It's just the culture." Another sub-theme that I want to call out here, they talk about, quote unquote, the expectation that medicine is and remains top priority. So there's a perceived expectation that medicine is and remains top priority for residents even after becoming parents. Participants reported that their programs were supportive of them having kids as long as this did not impact their role as residents. So, quote from interview 15, "Everyone was very supportive of me having a baby as long as my priorities didn't really change." And then they do go through a lot of very interesting actionable solutions in terms of how residency programs can improve training experience of residents in parenting roles. And one of the sub-themes that I see here, and it's described elsewhere in the literature as well, is optimization of support for breastfeeding mothers. So, many residents had worked at centers where there was no readily available room to pump, and participants described pumping in bathrooms, bringing portable freezer packs, or walking great distances to find an appropriate location for pumping. So participants, including both mothers and fathers, recommended that all facilities have an accessible space for trainees to be able to pump and store breast milk. Now, it's a pleasure to introduce Dr. Maggie Binder, who is joining us today. It is such a pleasure to introduce Dr. Maggie Binder, who is joining us today. Maggie Binder is a pediatrician who just completed a fellowship in pediatric hospital medicine. She attended Case Western Reserve School of Medicine, where she met her husband, and they couples matched into residency in North Carolina and then returned to Cleveland for her fellowship. She will be starting a new job as a hospitalist this fall. Outside of her clinical interests, Maggie is passionate about medical education and developing new curriculum for pediatric residents. Maggie and her husband, Dan, have 2 daughters, and as a family, they love to go to the zoo and spend time at the pool. As a more personal fun fact, she gave a speech at my wedding, so I'm going to sound a little bit biased towards her. Maggie, thank you so much for being here today.
Thank you so much for having me, Frances May. You've had such incredible guests on the podcast so far, so I'm really honored to take the time to chat with you today.
Well, the last time that you and I spoke, I was trying to convince you to get bottle service. And so,
yes.
I kind of thought if you were on here, then you wouldn't be able to say no. Now, all the peer pressure of it, you're gonna agree. We're gonna get bottle service.
Well, how I remember it is the last time we spoke, you kind of came to understand really what it means to get bottle serviced and the cost and the noise and the time of night. So I think I can still weasel my way out of it.
The time of night is going to be your saving grace because I cannot be up or be seen out after 9 p.m. So
if we could do a 2 p.m. bottle service, I'd be in.
Okay, you heard it here, and I have a recording. Yeah, exactly. This is legally binding.
You heard it here first.
Okay, well, I really appreciate you being here, and I'm so excited to learn from you and really hear about your experience and your expertise in this area.
Yeah, I'm so excited to chat.
To start off, can you share a bit about your background, your own journey in medicine through fellowship, and then, of course, how you balanced your career with becoming a parent?
Absolutely. So as you mentioned in the bio, we met in medical school at Case Western. I'm actually from Florida and then ended up in Ohio for undergrad and then in Cleveland for medical school. And that's where I met my husband, and he kind of ties into this story since we couples matched and then got married and had kids and the whole thing. So we ended up couples matching at Wake Forest in North Carolina. He is a family medicine physician and I'm pediatrics. And that was around the time that pediatric hospital medicine came into its own entity as being board certified. So I had to make the decision to pursue fellowship or not. And ended up doing a chief year in that time to really help cement my decision and kind of pad my CV a little bit, make myself more competitive. And as all of these decisions were going on, we got married intern year and then had our first little girl at the very end of my second year. Is that right? Yeah, that's right. Time really blurs together. And then I had to go through the match process all over again and kind of leave it up to the match gods as to where we were going to end up. But we feel very lucky to have come back to Cleveland where we have his family here to help support us. So I did my 2-year fellowship here in Cleveland. And then during that time, we had our second little girl who's now 7 months old. So I've had the experience of being pregnant and a parent, both as a resident and as a fellow. And so I'm happy to kind of share what I've learned along the way.
Absolutely. Well, I mean, one topic that you have written about in the past, but it's a commonly asked question, with having your first daughter, what did planning for that look like in residency? How was scheduling adjusted accordingly?
Yeah. So I was really nervous, honestly, to get pregnant and to become a mom in residency. I just wasn't sure that I was going to be able to handle being a resident and being a mom, especially because when we were in North Carolina, we were by ourselves. We really didn't have any family support there. But we kept talking about it, kept thinking about it. And I think I just came to the realization, especially as a trainee in medicine, that it's never really going to feel like the perfect time. I joke that when we first started talking about it, I told Dan that I wanted to wait until my first PICU rotation was over to get pregnant, because I just envisioned myself like puking in a bucket on rounds outside of like a critically ill patient's room, which just didn't feel like a good look. So we waited a little bit, and it ended up, I had to rearrange my schedule when I got pregnant, and ended up being pregnant in the ICU anyway. So, my schedule had to change a ton once we realized I was pregnant. Different people go about it different ways in terms of prioritizing what they're going to do while they're pregnant versus what they're going to come back to after leave. I think my chief residents knew that I was pregnant before our parents did. My first call was to daycare to get on the list for childcare. And I think my second call was to the chief residents to say,
oh my gosh,
yo, we got to like fix the schedule, because I'm going to be out. So I feel really fortunate, because in pediatrics, we care for children. And so there's a very, I think, receptive culture to when trainees want to become parents and have children themselves. And it's something that is not that uncommon. And so the chiefs were able to rearrange the schedule. But the program coordinator was a huge help. My program director was a huge help. I ended up choosing to do as much inpatient and intensive kind of rotations while pregnant, so that when I came back, I was really outpatient and elective heavy. But, that meant that I was just like going through the ICU, the ED, months of inpatient just to try to hammer it out. So it can be tough kind of no matter how you rearrange your schedule. But that's certainly a number one priority, because the last thing that you want to do is, screw someone over if you don't, get the schedule switched.
Totally. And, if you could go back, would you do your schedule the same way, kind of inpatient heavy during pregnancy and then switch to outpatient and elective postpartum?
I think I would. We were really fortunate the way our schedule is set up. This is probably going to blow your mind. We only did 4 24s in all of residency. So I know you're like, I can't imagine.
I'm taking that personally. Continue.
Yeah, I know. But I'm not a surgeon, right? Like, it's peds and some of, we were very, very lucky. So I just couldn't imagine like coming back from leave and having an infant at home and then being gone for 24 hours or working nights and missing all that stuff. So I don't think that there is a right way to do it or necessarily an easy way to do it. But what was right for me was to get as much stuff done while I was pregnant, because it's only going to, my experience was that it's only harder to work when you have the baby and you're trying to pump and you're sleep deprived on top of being a resident, versus like just doing it while you're pregnant and you still only have yourself to take care of.
Totally. Well, and from what you remember back on like outpatient and things like that, were you able to make it home, I guess, before her bedtime most evenings on that schedule? That meant that you could do bedtime?
Yes. So on that schedule, I was making it for bedtimes. I was home not every weekend, but more weekends than if I had been doing inpatients, where we did kind of 12 on and 2 off. So I had most of my weekends, other than some call weekends, home with her. We would have major holidays off because clinics were closed. So I felt like I had more time with her. I didn't have to be in until 8 as opposed to being there at 6 on an inpatient rotation. So it felt like I could optimize the time that I had with her as much as possible.
Yeah, that's wonderful. It definitely makes sense. In the postpartum period, what did your maternity leave look like? And did that impact your training in any way?
Yes. So since I've had my first daughter, the ACGME actually has since then come out with a policy that allows resident trainees 6 weeks of parental leave for delivering or non-delivering partners. So when I had my daughter, my first daughter, there was none of that. So anytime you took off, unless it was vacation time, was docked against your training. So I took 9 weeks off the first time. It was all of my vacation time for that year. And then it was some sick days, some like free sick days that I hadn't used. And then it was time off that I ultimately had to make back. So I owed the program about 3 to 4 weeks when all was said and done. Thankfully, I was going into a chief year at that same institution. And so my program director, I learned that this is a thing that could be done. The program director, at least for pediatrics, can kind of go to the board and ask for that time to be forgiven entirely. So outside of ACGME, but actually like the ABP, the American Board of Pediatrics, he was able to go to the board and say, look, I still think that she is qualified and ready to become a board certified pediatrician without these 3 weeks. And that was approved by the board. I don't know if it's the same for all specialties, but that's certainly something to look into. You have to be, in good standings with the program. Certainly, you have to have done all of the core curriculum. So really what you're losing is that elective or flex time that you would normally have. So that's what I did the first pregnancy. So I did 9 weeks and owed about 3.5 or 4 weeks back to the program.
Wow.
In fellowship, I was able to take advantage of that 6 weeks. So I took 12 weeks with fellowship, which was really nice. So 6 weeks of the projected time from ACGME, 3 weeks of vacation, and then I ended up taking 3 weeks of unpaid leave through FMLA that I then made up at the end of fellowship. So instead of ending kind of June 30th, I ended, 3 weeks into July.
Wow. That's incredible. I mean, I guess like if that ACGME policy had existed during your first pregnancy in residency, would you have taken maybe even more time than you were able to?
Potentially. I mean, 9 weeks felt like luxurious for a trainee, honestly. I may have. I think it's hard to say. It's the longer time you take off, the harder it is to get all of your requirements in without extending. But potentially, I mean, having that 6 weeks, it's really the bare minimum time, but at least it's something that's protected. And because there's no kind of national or federal law for paid parental leave in the country, having the ACGME come in a couple years ago and kind of mandate that for resident trainees, I think was at least a good step in the right direction.
Yeah, that's incredible. And I do think that, in terms of reception, I would imagine that it varies program to program, and department to department and things like that. But like in your training experience, were people very understanding? There aren't snide comments or people being like, well, how was your vacation? Or like, you just had a baby to get a month off of work. Like, I'm on to you.
I do think I was really lucky. Like I mentioned, pediatrics and even family medicine, like my husband's experience, tend to be very kind and lovely and warm people that are understanding. So I didn't really experience snide comments. And there were residents even in my class and classes before me that had babies as well. So it just seemed like it was kind of like part of the deal. And we were kind of like a medium-sized program, so there was enough flexibility within the schedule. But, I'm sure when my co-residents got the email being like, sorry, dude, your schedule's changing and we can't tell you why. That's tough for anybody to go through. But I think I had a relatively good and positive experience with it.
So what was your husband Dan's time away from family medicine residency like?
Yeah, so he only took his vacation time off. So he took, I think, 4 weeks off. And so actually my first daughter, she was born at 38 weeks instead of 40 weeks. So not premature, but early for when she was supposed to be due, which kind of messed up the schedules that we had so carefully plotted. So he ended up just having to call out of work for a couple of days and then went back to work until his scheduled vacation time. So he worked for about a week and a half right after she was born, and then took, I can't remember exactly what 2 to 3 weeks, I think is what he ended up taking off. So yeah, he used all of his vacation time. There was no paternal leave at that time.
Right. But you mentioned that now, like the new ACGME rules, that's included. It's maternal and paternal.
He could have gotten so men now are included in that, or the non-delivering partner gets the 6 weeks as well.
That's incredible. Well, and of course you were at two very different points in your career when you had your first and second daughter. And so can you kind of compare and contrast those two experiences for you as mom?
Yeah. Oh, for me as mom, my fellowship thankfully was very, very flexible with my schedule. And most other fellowships are not. Hospital medicine, since you go into it having already done so much time in the hospital and residency, it's really to kind of build up those skills and build up skills outside of the clinical setting. So it's not like a surgical fellowship or even other pediatric fellowships where you're like in an ICU doing 24s, doing calls. So that really worked in my favor quite nicely with how flexible my schedule was. And I was able to take more time off. So when I came back, I was feeling a little bit more prepared. I had done the whole finding bathrooms to pump in at work thing, like balancing being a mom and working. Certainly having two instead of one had its own little nice twist to it, but I at least felt more prepared the second time to leave her and to be away from her during the day. And two, I had a better idea in my head of how I was going to manage everything compared to the first time. The first time you just feel like you're treading water, you're trying to figure it out as you go. So I did feel more prepared the second time.
Oh, I'm sure. I mean, do you kind of get tips? Like the first time, I guess, what can we tell kind of expecting resident mothers? It's like, where do you even get all the good info about places to pump, places to store, breast milk, things like that? Yeah,
it's wild. A lot of it you have to kind of figure out and survive. I was really, really lucky. My co-chief, Katie Garling, she had a daughter before me in residency. Her oldest is about 9 months older than my oldest. So she had just gone through everything really right when I was getting pregnant and having my first. So I don't know what I would have done without her. I feel like I was texting her every day, every other day, being like, what pump did you buy? How did you clean your pump parts at work? Where did you put your milk? Where did you pump? Like, what do you do when daycare is closed? Who watched your baby? Like, all the logistics, she really was so important to me to help me figure that out. So if you can find someone in your department, whether it's a co-resident, a fellow, an attending, someone who's just navigated the system, it's nice to be able to kind of form that bond and get all of the tips from them. Making sure that you have reliable childcare is really one of the biggest hurdles, I think, to returning to work, because there's going to be days that daycare is closed. There's going to be days, if you're able to have a nanny, that your nanny is sick and can't come in. So you almost need like a backup plan to the backup plan. So finding someone that's just been through it can be, she was a lifesaver, honestly.
That's incredible. Yeah. It sounds like you're lucky to have had her, especially because she had so recently gone through the experience. Like that probably helps too, like keeping all the tips fresh and, things like that. It's interesting because I know you alluded to earlier, like there maybe isn't a best time. There's certainly not a one size fits all time for resident physicians to approach the decision-making to start a family. I mean, do you think that there are some broad strokes better than others? I mean, of course, I genuinely don't know. So I'd love to hear even the thought process, or in medical versus surgical specialties, what are ways in which, you would imagine that they differ.
Yeah, I do believe that there's never going to be a perfect time, but if it's something that is important to you and your partner or your spouse, or you're doing it by yourself and you really feel like outside of work and who I am as a human, separate from being a doctor, because right, you're allowed to be a person and to be a doctor. If it feels right, if it feels like now is the time to have a baby, then you can make it happen. I mean, I was certainly not the first person in training to ever have a baby. I will not have the last. I will not be the last to have one. So it really comes down to planning and preparation as much as you can. Now, certainly you can plan till you're blue in the face, right? You plan and God laughs. You will not be prepared for everything, but there are things that you can think about ahead of time. Like, do you have the money to financially support someone else, right? Like, we all know that residents do not get paid bundles and oodles of money. So just to make sure that you have the financial stability to raise a child while as a resident, because childcare, things that the baby needs, those things are expensive. My hospital bill for each baby was $2,000 to $3,000, and that's outside of all of the regular OB checkups and ultrasounds. So just the hospitalization alone with insurance is expensive. So, if you can make sure that your finances are in line to the best of your ability, that's a good place to start. And then start thinking about childcare. Like, is there reliable childcare that you can get into with a reasonable amount of time, that has flexible hours, that's open early, that stays open late, because you're going to need to drop your kid off at 7 a.m. You're not going to be able to go somewhere probably with like a 9 a.m. open time. So I think that those are important things to think about. And then, do you have any extra support? Do you have people in the area or people in your life that can help you raise the baby? Honestly, I'm very thankful for the fields that we were in, that we had flexibility and understanding. But I would imagine if you're in a surgical specialty, or you're in somewhere where you're going to be doing 24s or have a really tough schedule to come back to, you're going to need help, And so if you're in a surgical specialty, maybe thinking about, okay, I'm a med student. I think I want to have a baby early on in training. Maybe I should prioritize ranking places that are closer to my family or closer to where I have support systems, so that when I have that baby, I have backup. I have a grandma, a grandpa, some other support system in your life to help you with the baby. Because it's hard to do it alone. It's hard to do it with just you and your partner. So if you're in something that's more demanding, the more hands, the better.
Yeah, it takes a village. I mean, honestly, I kind of think it takes a village to like keep a resident alive themselves, like, yeah. Depending for all of training. But I really love that. I appreciate everything you're saying, because, you make a lot of sense. You're a very like logical, stepwise person. And I think that the approach of let's just be as prepared as possible, with also, not being too type A and accepting that some crazy things could pop up.
And they will.
Yeah. Well, that really makes sense as the sweet spot. And, we definitely, like, here on Promising Young Surgeon, we'll definitely get more into some minutia of like the female surgeon as a mother experience, because I do know, like, my experience in training, it was just littered with horror stories. And one example of one that I think of is, in one of the really like competitive surgery heavy subspecialties, there was a woman, she was a fellow, and she was back at work a couple days after a C-section. Yeah. And at the end of the case, everyone kind of looked at her, and she had bled through all her bandages, all her scrubs, just like, coated in her own blood at the end of the case. It's like, that kind of sounds like a horror movie.
Yeah. I mean, a C-section is major abdominal surgery, and whether you deliver vaginally or a C-section, like, your body is recovering from a major trauma. So for her to have to do that, nobody should have to do that. And we're not certainly there are other people in the country outside of trainees or physicians that are returning to work way earlier than they should. But it's a horror story. You shouldn't be away from your baby that early. And your body and your mind are just not in a good spot to be doing those things. I mean, I can't do surgery on the best of days, but I certainly could not have done it 3 days postpartum, even with the appropriate training. Like it's scary and it's not safe for her or for the patient.
Totally. And so those are just some of the cultural things. Like, hopefully that's less acceptable. That was several years ago, and hopefully people are, dissuaded from doing that kind of thing today. But definitely, I mean, I want to take time before we even move on from your personal journey to like these bigger picture ways that we can improve things for residents. I do want to make sure that we take time to be like, all right, the literature does describe absolutely positive effects of experiences as a parent on residency training and clinical practice. So like, I'd love to hear about how your life as a doctor, your practice as a hospital, medicine pediatrician has been very positively impacted by, of course, becoming a mom.
Yeah, I believe that I'm a better physician because I'm a mother. Again, pediatrics is really easy to kind of gain skills as a mother when you're raising a baby. I just think about all of the insane things that I was counseling families on before I had a child, in the well child checks, in their clinics, or just not realizing how hard the things are that I was asking them to do. And so now as a mother, I'm better able to empathize and to understand and to put myself in their shoes. And even if it's something that I haven't experienced myself, I can at least say to them, I really can't imagine how hard this must be or how difficult this must be. I mean, I had to do phototherapy with my first daughter at home. And I remember thinking, how hard could it be to have a baby at home on phototherapy with a Billy blanket? It's just a blanket. Wrap the kid up, walk away. At least you're not in the hospital, right? And it's not that easy. Or what we call triple feeding, when you're feeding the baby, you're pumping, and then you're feeding the baby what you pumped. That takes all day for a newborn, right? To feed, to pump, to feed them what you pumped. You're feeding them every 2 hours. It takes all this time to do it, right? Like, you're just not allowing any time to sleep or to rest or to be normal. And there are some things that you can't understand, or it's more difficult to understand until you've been through something similarly. So I think it's made me, just in general, even outside of pediatrics, I think I'm more patient now. I'm more empathetic. I'm a better listener. I got to listen to that toddler talk all day. I can sit and listen. Like, I'm ready. I'm prepared. I got those skills honed. And then just specifically as a pediatrician, kind of going through those things myself that some families have been through, or really realizing, like, thankfully, neither of my daughters have had to be hospitalized, but I deal with kids in the hospital every single day I'm at work. And it's very normal for us to see kids in the hospital. But to those parents, right, it could be the worst thing that's ever happened to them to have their child in the hospital. And I think you know that as a human being, you know that as a physician, you know that as a pediatrician, but I think you can understand even more as a parent how terrifying, isolating, powerless you would feel in that situation. So I think it's made me a better doctor. And we made the right decision for our family, for sure.
That's really beautiful. I love that. And I will attest to, you were actually a very patient person even before motherhood. And so now I assume you've reached, you're reaching like a truly Zen level. Where
I try, not every day, not all the time, but I do my best. I try.
And I think but that's a lesson that's very broadly applicable, I think, to physicians. Like, I'm a person who has had immediate family members diagnosed with cancer, several deaths in the immediate family, and that has made me a better physician. It makes me a better surgeon. It makes me just a person who's more understanding. Not only that, but another example I'd think of it as is that I'm terrified of needles. And so you bet that I I empathize. Yeah. Well, when people come in, they're like, oh my gosh, I don't want this peritonsillar abscess drained. That is the biggest needle I've ever seen. I really super don't want this. I'm like, honestly, I 100% get it. I don't skip steps such as we can use benzocaine spray. It's called hurricane spray, you know, and we can nicely do that before even injecting the lido with epi, before even inserting a spinal needle. You know, there's multiple steps here, but like, honestly, people skip the hurricane spray step all the time because it's time consuming. It's another, you know, it eats up a couple minutes. You have to go find the spray, whatever. Well, I think that's really worthwhile because I'm very capable of being like, well, what would I want? I guarantee you, if you guys could see me, if we like live stream my next dentist visit, it's me being like, hey, what's up? Shot. Yeah, no, exactly. Like no injection, spray me first. I ask for Emla cream every time they have to draw my blood. Sometimes they're like, no, we don't have that, you know, but like, I get it. And it makes me really understand the patient experience a lot more. So I certainly, it makes a lot of sense, everything that you're saying about your identity, both as a mom and then of course now a pediatrician who's taking care of these sick kiddos in the hospital.
Yeah.
I got to say another personal anecdote about a time that I was a moron is when, you know, I have done sublingual immunotherapy in the past. I have like pretty decent environmental allergies. And sublingual immunotherapy is an alternative to allergy shots where instead of, you know, making up vials of shots, you get a little vial made up for you where you just put like a drop under your tongue every night. And it's very nice. Like, so instead of going to the doctor's office and needing a weekly shot, you just do a drop under the tongue every night. And that's such a thing that's like, anyone could do this, right? Like a monkey could do this. So there is a full pre-sublingual immunotherapy, like nurse visit where you get educated on like how to draw it up, how to hold it under your tongue for 2 minutes, things like that. And I've even coached people on all of that. Well, when it was time for me to do my sublingual immunotherapy, I was doing it for a few weeks and I was like, honestly, this is making me very sick. I was like, I don't know what's up. I was talking to my friend and I was describing what I was doing to her. And she was like, you are doing like 8 times the appropriate dose. Cause I was like, yeah, it really like my whole floor mouth swells up. My throat swells up. Like I am
I feel miserable. I can't breathe. Yeah,
exactly. Like I'm not in anaphylaxis, but like kind of feels like I'm close. Do you think that that's weird that I'm getting like, I'm just making myself so ill with this? And yeah, she was just dying laughing at me. She was like, oh my God, like you're way overdosing. Like you legitimately could endanger yourself this way. And I was like, oh, okay. Oh. Well, I guess it's not the logical amount that you would draw up with your like little syringe.
Never as easy as we explain it.
Yeah. So that has also, you know, these types of things, it's good. It's good because it humbles us and it makes it easier to then even tell patients like, hey, I anticipate this step like might trip you up. Yeah. Please no, don't do it.
What to look out for.
Okay. I really appreciate you sharing, you know, so much of your journey with all of us. And I want to talk about, very importantly, you know, with your passion for medical education and even ways that the system can be improved to make things better for residents who become parents. Yeah. It's like, what do you think that programs can do to support the resident? One, at the time that they say, okay, so we're doing it. We are now announcing our pregnancy. But then also, what can a program do to support them through each stage?
Absolutely. So, and it's hard to, I think, to generalize to all programs. Again, pediatrics, it's very easy because what we're bringing into the world is a little baby and we are being trained on how to care for babies. So I think that there are some things that are innately easier to build in within a pediatrics residency or fellowship. But I think a lot of the themes or ideas can hopefully be extrapolated into other specialties as well. You know, the first thing that I think is important for programs to do, especially when a resident is coming to them with this sacred, private, personal information. I would hope that all programs out there, whether you are an ENT or a pediatrician, right, that you should be met with maybe a congratulations, maybe some positive words, right? Like there is a lot of stigma around becoming a parent during residency. And they have published studies where people have chosen to delay parenthood for fear of what their program will think of them or what their co-residents will think of them. And residents tend to be the age that most people in the country are thinking about having children if that's something that they want for their life. So it's going to happen to residents, planned or unplanned, right? Like there are going to be residents forever and always that get pregnant during residency. And I think it's important that these programs don't act like it's the most insane thing in the world that they've ever thought of, right? They should be prepared to support a resident going through a pregnancy or a non-delivering partner whose, partner is bringing baby into the adoption. I mean, there can be lots of different ways, but it should not be met with, well, this is the worst thing that could happen. You're totally messing up the schedule. Did you even think about Johnny's vacation and how you're gonna, it's not acceptable at this day and age. So, if there's program leadership out there, this is something that you should be prepared to guide a resident through. I think the ACGME 6 weeks is a really positive step in that direction. It's guaranteed. And it should not affect the time that you are required to train. And so knowing that you have that at least at a minimum, if you're getting any pushback from your program, you can say, look, it's right here. It's a policy from the ACGME. This is what at minimum I expect. In terms of other things that programs can do to support, especially residents coming back, when I was a chief, my co-chief, who I mentioned earlier, Katie and I were able to develop and create a curriculum for residents returning from maternity or paternity leave. And actually, we were able to build the curriculum so that even if you weren't a parent, you could take the curriculum in certain sections and learn more about what it means to parent or to raise a child. And we call that a parenting elective. That's what we were able to develop. And so residents were able to tack that on to the end of their leave to get an extra 4 weeks at home as sort of an introduction to, all right, I got to get back to it. I have to start going to clinic again. Maybe I'm doing some telehealth now that that's really ubiquitous in the country after COVID. Start building in those clinical requirements, but still have a lot of independent learning time that they can do at home that incorporates the care that they are providing to their child and really highlights everything that they're learning that can be then applied to their care as pediatricians. Now, again, I don't know that you could totally, an ENT surgeon could totally swing like, look, I'm taking care of a baby. Give me credit for graduating to be an otolaryngologist. But what I do think that's come out of COVID that's a good thing, a lot of places are now set up to do virtual medicine. And most programs will have some flexibility in the schedule to do something to have like electives. And so if you're able to think far enough ahead to create your own elective where you can spend that time, applying your specialty, but doing it at home or doing it in a way that's less intensive or doing more things remote, that's a way to help ease your transition back into the clinical practice of being a resident. And I think if programs and residents can start thinking outside of the box, how can I do something like this that fits into my specialty, that fits into my career, but gives me some flexibility to still be at home with my child? I think that that is really, would really be a great way to support residents coming back from parental leave.
That's great. Those are all great ideas. And I mean, I especially think like the parenting elective, yes, it makes perfect sense in the peds world. Yeah. But of course, I mean, there's a decent cohort that's med peds as well.
Certainly.
And even in ENT, like it's on our boards. I mean, pediatric ENT is a very large part of our resident education. And then of course our board exams and things like that. So
practice finding those TMs at home on your baby, right? Like that's, you got to find those as an ENT.
Yeah. Well, just look at the guidelines for a lot of these common things. Honestly, one thing that I feel like I wish I had more of, just because it's come up multiple times this week, is maybe like more tips and tricks on placating kiddos. Because what's tough is we have like this age range. And again, like, I'm not a pediatrician, don't listen to me, but I would call this age range tough because 5 to 6,
under 18? 5 to 6.
Yeah. I mean, 5 to 6, maybe 4 to 6, but I do a lot of pediatric foreign bodies, ear foreign bodies, nasal foreign bodies. And it's tough because, like, if you're teeny, if a 2-year-old puts something in their ear, honestly, like, my team and we're stronger than a 2-year-old. Like, I can just get that out of their ear. We do a nice swaddle. It's not very traumatic on anyone other than like my ears. But we can do that safely. But we've just had a run of, I pulled a sticker gem out of somebody's ear this week. I had a poop ear the other day. That was also not my finest day. Stuff like that, where by the age of 5, we are no longer stronger than many of those kids. They can't be swaddled. And so then now we go to sleep in the OR.
Can't really be reasoned with either.
Exactly. You can't barter with them. Because like a 7-year-old, you could be like, I'll give you 4 stickers. And then they're like, no, 6 stickers. And then I'm like, honestly, I will give you 6 stickers. Like, let's just get this done. Yeah. And they'll negotiate that way. So, many of us physicians who are not in peds directly, like, we still have
to take care of kids.
Yeah, exactly.
Yeah,
so
that's a great idea. And like, thinking of a way, whether you kind of start learning about, I don't know if you have this or if you have this where you trained like Child Life, like some of the programs that Child Life will do to placate or to be able to explain the procedure, or even talking to parents is different than talking to an adult patient, right? So I agree. There are skills that you can gain from parenthood or from being around children that should be able to relate, or things like, okay, I can learn about child life while at home taking care of my kid, or I can better understand the anatomy by reviewing these things on a kid compared to an adult while at home with my kid, right? You can really develop goals and objectives to meet whatever your standards are for your boards. And as long as you can say, like, this is the activity I'm doing at home, this is how it relates to my goals and objectives, and this is how it relates to boards, that's a great space where a program could support the development of that type of elective. And what we were able to do is kind of build a couple of like check boxes along the way to make sure that someone is doing what they're saying that they're doing. Like, is there something you can type up and present? Is there a 10-minute PowerPoint you can give at the end of it to show all the reading that you've done, right? Some work product that tends to go a long way as well at proving that you've been productive.
That's great. And yes, I'm a Child Life super fan. I don't have that currently at my rural community hospital, but like, kiddos, they get lacerations. We used to have a fair bit of like dog bite lax and things like that. And they were just, they were able to work miracles with like an iPad or, some puzzle toy. While we were
shiny
working.
Thing. Yeah.
Yeah. And the last plug I'll make too, just so that it kind of, if somebody is thinking through this and they're like, okay, well, I'm ophthalmology and I don't know how that applies. It's like, think through from our standpoint, even though I'm not a parent, I am responsible for knowing certain milestones developmentally as they relate to speech, for kids. That ties in directly to their hearing. I do a lot of tubes in speech delay kids. Well, that means that you need to have a sense of how many words a 2-year-old, a 3-year-old, and so forth needs to be at, because we do ask that of parents. And of course, I'm one of those people who doesn't personally know a lot of kids. And so, I'm sure you can imagine this, Maggie. Like, I walk into the room and I believe in treating people the same way. So I'll walk in and I'll be like,
Greetings, madam.
Yeah.
How's your day?
Oh, totally. It'll be like a, 6-year-old boy, and I'll be like, "Good afternoon, sir." Like, and now I'll shake their hand. I shake
Smith,
everyone's
thank
hand.
you for coming today.
They'll shake your hand though, and I think that they feel included. And like I think they feel included because I shake their parents' hand, I shake their hand. Most kids will shake my hand, if only because it's like the first handshake they've ever been offered, maybe. But it's so funny because, I do treat them respectfully, and I've had a couple 6-year-olds where like months later, a cute old lady comes in and she's like, "Hey, I'm here because honestly, like, you see my grandson and he's obsessed with you. Like, you're the only thing he talks about at home."
Awesome.
And, since I don't know any kids, like, they're very stoic. Like, in my office, he's never said a peep. And she's like, I mean, it's a year later and he can't stop. The handshake, the stickers. So it's very important work, but it is so different from what we do with adults because I feel like if an adult is very stoic in clinic, they're not like also raving about you at home secretly.
No, right? Like kids are not little adults, right? Like I don't know if that gets said around the surgical world, but that's something that we tend to say all the time, right? Like kids are not little adults. You can't just take what you've learned and directly apply it to a 6-month-old, a 6-year-old, a 16-year-old. So there are nuances to learn about kids. I think to your point, in every specialty for that ophthalmologist, right? Like infant's vision and how it develops over those first weeks to months is something, I still look up and need to remind myself of, right? So there is something to know about kids and caring for them probably in the majority of specialties.
Well, I do want to ask you for one more pearl of wisdom before we finish up here. But what is your advice to co-residents? Like, how can they best support a new mom, a new dad?
Yeah, it's, my experience was so wonderful. My co-residents really did feel like a little community that I was a part of. But like I mentioned earlier, like it's tough no matter what to have your schedule changed, interrupted, switched around. You plan your life out as best you can when you're a resident to try to go to that wedding or your mom's birthday or whatever it is. And then to have something upended for something that's out of your control is really hard to do. And I think you already feel guilty for doing those things to other people. Like we feel that guilt. So as best as you can, just trying not to, I don't know, say anything rude or immature or to make it feel like we're, someone going on leave is taking advantage of the system, right? I think that can go a long way. Even if you don't do anything for them, what you can do is kind of reserve those comments to really just to, as best you can, try to create an atmosphere and an environment of kind of understanding and collaboration. Food, right? There's no time to cook. You can't even remember how to turn the stove on when you're like 3 days postpartum. If you can cook, you can drop off a meal. That's a really nice thing to do. Nice. Ordering some crumble cookies on DoorDash. That's what I did for a friend when she was in a different state who had a baby. I was like, you know what? They got DoorDash in other states. Send her some crumble cookies. There's lots of good ways to support. If someone is going to choose to pump or to express milk, when they come back from leave from their baby, it can feel like, oh, there they are. They're taking a break from work again, and just think that we are doing kind of the same amount of work while pumping, while having to take that 30 minutes out to go pump and come back. And often, especially residents, most of the people that I talk to are trying to work while pump and do their notes or reply to things or text back to nurses. So again, I think it's just another good time and space to just try to be understanding and know that probably that person is doing everything that they can to not give other people any more work, but to really kind of do their work and pump at the same time. So I think just trying to be understanding.
I think it's really helpful for you to kind of hit home these themes of like, this is all increasingly destigmatized. Mm-hmm. And also, I wish you didn't have to say it, but you've mentioned a couple times now, like it would be really helpful for people to not make derisive comments about it, right? Like at the
Right.
attending level, I've heard attendings say in response to the news that someone's pregnant, one of their residents is pregnant, just saying, you shouldn't be having a baby. You should be focusing on studying and learning this for surgery. So, I mean, again, super unhelpful type of rhetoric and also unnecessary. And I think that one of the takeaways that I get too when you talk about all this, it's like, yeah, we should give that person the benefit of the doubt, right? Because a pumping break is not a smoke break at work. And honestly, it seems unbelievable that a resident would go so far to just get like 3 weeks of vacation, now 6 weeks of vacation, that they'd be like, all right, I'll do it. Like, I'll get pregnant.
Yeah, I'll have a baby just to get a couple extra weeks off.
Yeah, like it's not.
People are doing that, no.
Exactly. So we shouldn't treat it as such. Like, I really do not view it that way. And if somebody was like, hey, respectfully, I'm recusing myself to go pump, I would be like, yeah, absolutely. Like, I'd be very understanding of that. And also, I don't want to switch places with that person. I wouldn't be like, again,
man, I wish I was
going on a 30-minute
somewhere.
vacation. Yeah, no, like I don't envy you. Like, that sounds really difficult. And the fact that you're doing all of this, like, good for you for showing up to work. I probably wouldn't show up to work under these circumstances. I'd be like, you'll never see me again if I had to do all these things at one time. So just important for everyone to kind of keep in mind. Like, I don't think that, yeah, childbearing is like this long play at a vacation or, you know, refusal of duties.
It doesn't feel like it on this end, you know, but I really appreciate it. I feel like the podcast and all the work that you're doing, right, is really about changing the culture of medicine or doing things that are within our control to make the training environment better or less malicious or, you know, just a place that you want to be. And so there are things that you cannot control, but there are things that you can control. And just like what you're saying, unnecessary comments or chit-chatting about someone behind their back or, you know, it's just unnecessary. I think people, no matter what, are just trying to do their best. And, you know, I think most people in medicine tend not to be slackers, right? And they want to get their work done and provide for their family.
Yeah, I love that. Well, I do close always with our favorite question. Do you believe in karma?
You know, Frances May, I've listened to a lot of these podcasts. I feel like a guest has yet to answer this question correctly. Are you ready? Because by karma, I assume that you are talking about the rumored Taylor Swift album that has never been released. Is that the karma that we're referring to?
Yes, finally. Yeah, this is why I had to bring like a BFF on to be like, everyone missed this.
Yeah. Everyone's talking about do good unto the world, you know, treat others the way you want to be treated. This is not the question. The question is there a Taylor Swift album that we don't have access to? I like to believe in it. I do.
You believe in it? Well, when will we get our hands on it?
Maybe never.
If ever.
I don't know. That I don't know. But I bet she's always doing something. There's got to be something out there that we don't know about.
Always scheming. I love it. Well, yes. Again, you finally cracked the code. Now I have to like find a new secret question.
New question.
Maggie, thank you again for coming on today and sharing your journey and acquired wisdom with us. Where can our listeners find and connect with you online?
Yeah, thank you again so much for having me. I've loved having this conversation with you. You've had some really incredible guests with some strong online presence, which I am just in awe of. You are welcome to follow me on Instagram. It's at Mags K Binder. It's probably the best place to look for me. Feel free to shoot me a message or a DM on there. We can talk about more about how you can go about approaching pregnancy and residency or pediatrics residence or however I can help you.
Absolutely. Well, and also I do want to plug really quick. Look out for maybe more to come from Maggie in the writing space and development of medical education for residents who are exploring parenthood.
Absolutely. More to come.
I say exploring parenthood. We'll say undergoing parenthood or something. It's like, I guess, because you can't be like, I'm thinking about it. Not for me.
You can. You totally can.
Oh, well, but not at the point at which they've
not when you already
parenthood.
Have the kid.
Yeah.
No, once the kid, you can't return them usually. You can't put them back.
Yeah. So we'll say if you were considering parenthood or have recently entered parenthood.
I love it. That's perfect.
Follow me on Instagram at francismay.md and at Rethinking Residency. Visit my website, rethinkingresidency.com, to learn more about resident physician stories and ways that residents can most effectively navigate the game of residency. I look forward to connecting with you on the next episode of Promising Young Surgeon. If you enjoyed today's discussion, please subscribe and leave us a review, and feel free to share with your colleagues. If you have any questions for future episodes, email me at pys@heyinfluent.com.